Well, thank you guys for all coming out on this kind of chilly evening to talk about metabolic diseases in horses. Emma actually picked this topic. She thought, she goes to a lot of barns and she feels like this is an area that owners get easily kind of confused about. And I would also say I think vets can get very easily confused about because it's not as black and white as we would hope. Just a reminder that these programs are for the USEA Grooms Association, and that's a great program that aims to drive educational opportunities for grooms and promote equine management and welfare. So thank you all for coming and donating to that. And also a thank you for Emma Ford and Michelle Coppin and Tara Boswick for coordinating the lecture series, and Bruce's Field for having it, and then Shepley's and all the other sponsors. I'm kind of bummed I don't get to give the big gift away at the end. Emma had promised me that, but it looks really good, so whoever gets that next week. So just a quick bio on me, because then I want to get to the good topics. I grew up in Western Mass and was an eventer. I first came to Aiken in 1995. Things have changed quite a lot in the last 30 years here. I went to Wake Forest, and then I was a working student for 2 years before going back to vet school. And I interned and worked at Southern Equine here briefly, and then also at 3H Vet in New Hill, North Carolina. And then I decided to go back and pursue an internal medicine residency and a Master's of Veterinary Sciences at the University of Illinois. I became board certified by the American College of Veterinary Internal Medicine in large animal internal medicine. I was an associate veterinarian at Ocean State Equine in Rhode Island. And then finally, in 2021, I started my own practice, KE Equine. And I do ambulatory equine internal medicine services and consultant in the lower New England states. So tonight we're going to talk about equine metabolic syndrome and then Cushing's disease, and then how they kind of relate together, rules for competing horses that have these syndromes, and kind of our prognosis and what we can really do now, because I feel like with these syndromes and diseases, being proactive is the best thing to try to prevent issues. And then I have some good resources for owners. I'm going to have sections to answer questions, so if you can hold your questions till those sections, that would be great. So the real point of tonight's talk is like, why are we so concerned about equine metabolic syndrome and Cushing's disease in horses? Because both of those can increase the risk of the horse getting hyperinsulinemia laminitis, which can be a very debilitating disease. And for people who aren't really familiar with laminitis is we have this lamina. This is the sensitive lamina that attaches to the coffin bone. And then this is kind of the insensitive lamina that attaches to the hoof wall. And then they kind of connect together to hold everything together. And when we get hyperinsulinemia, again, we don't totally understand the process completely. We have insults to the blood supply to the lamina, and then we get inflammation. And then basically with all their weight, especially on the front feet, that starts to separate, and the coffin bone can kind of either, rotate or sink. And just even the inflammation of the lamina is very painful, because in that hoof capsule, there's nowhere for it to actually swell to. So that's really why we need to be proactive to make sure these EMS horses and Cushing horses don't develop laminitis. So just for people who haven't seen, x-rays, this is our coffin bone here, and then this is our hoof wall. I always put a marker on the front so I can tell where the coronet band is, so I can tell if they're sinking, and then I can also do measurements to see if there's rotation. And as we can see on this x-ray, there's a gas line there in the lamina. That tells me that we have laminitis, because we shouldn't have separation of the lamina and the hoof wall like that. And then you can also see that this coffin bone is tipped kind of down and back and is relatively close to the sole there. So that's not ideal. And then we have another example of a horse that's sinking. So this is where the coronet band is, and you can see the top of the coffin bone is down here, which is lower than it should be. And then you can also see these gas lines up there, which also tell me that there's been some changes to the lamina. And then the same horse on a different foot was actually sinking laterally, and you can see how this side of the coffin bone is much lower than this side. And then you can also see there's a lot of gas and damage to the coronet band on that side. So there's a lot of different ways that laminitis can affect the foot. It can rotate, it can sink, and we can even have laminitis where we don't have any radiographic changes immediately, but then we can see these down the road. So some common clinical signs of laminitis is the horse will be lame really at the walk, especially when you first start them out, or if you ask them to turn and they have to put more weight on one leg versus the other. And they're usually going to be lame on both front legs. We can get laminitis behind, but it's not nearly as common because they don't have as much weight on the hind legs as the front legs. And then we get this laminitic stance that this pony here is kind of showing us, where they put the front legs out in front and they don't really want to put weight down, and they don't really want to put weight on the toe of the front feet. They become very reluctant to pick up their feet. So if you're trying to clean out their feet and you're like, why can't I pick up this foot? It's probably because the other foot is really painful. Some of them will have increased digital pulses. Some of them will have heat in the feet, but both of those can kind of come and go, and those can be a little bit difficult to find. We'll see some bulging at the coronet band, especially if they're sinking. Some of these laminitics will get frequent foot abscesses. I mean, if your horse gets a foot abscess, don't freak out that it's laminitis, but if you have one that you're like, why does this keep happening? And then we'll see divergent growth rings on the feet too, and I have some good pictures of that later. So what should you do if you suspect laminitis? You really should contact your vet and farrier kind of immediately, because we want to get on this right away. I mean, they might not come out, but they can talk you through it on the phone of what we want to get started with. You know, we definitely want to get pain control. We want to reduce their movement. Probably going to want to do some metabolic testing. And then icing is a little bit controversial of, you know, when to do it. If you can do it immediately and do it consistently, like for 24 hours, you know, at least, but if you can only do it for like 2 hours a day, that's not going to be very helpful. And if we're not at the very initial point of it, it's not going to be very helpful. And a lot of these horses, by the time they're lame, we've missed that initial insult to the lamina. So the earlier we can see these cases and get involved, typically the better prognosis and the outcome. And it's really important to get the vet and farrier involved together, because it's going to take a team to work through this. And you know, metabolic diseases aren't the only cause of laminitis, but it is definitely the most common cause. But we can see laminitis with when horses get really sick with endotoxemia. We can see support limb laminitis if the other leg is fractured and they're putting too much weight. Black walnut exposure, different mechanical issues, road founder, and grain overload. And then there's something called winter laminitis, which has become like quite a term. And when it came out years ago, Dr. Mansman, who's in North Carolina, he's a podiatry vet that I studied under, and we said, I don't think there's a real thing like winter laminitis. So we contacted some vets in Alaska, and we said, do you see winter laminitis? You see horses stand in the freezer cold? And they said, no, we don't see winter laminitis. I see a lot of laminitis in the winter, and it's because these horses aren't working. They're eating a lot because it's cold, and they're getting laminitis because they're metabolic. So I think, I don't believe that there's a real winter laminitis, because in some ways, when they have laminitis, we ice them. So why being out in the cold would that change? So, you know, that's just my thoughts on it. So what exactly is equine metabolic syndrome? Now that we know why we want to avoid it, because we want to avoid laminitis, you know, it's a syndrome that's associated with inappropriate blood insulin levels, which increase the chances of them getting hyperinsulinemia-associated laminitis, which people also sometimes call pasture-associated laminitis. But I will warn you, they can get that just from a rich hay or inappropriate grain diet. They don't have to be out on grass to get you know, pasture-associated laminitis. So basically, when they consume a meal high in carbohydrates, their body produces higher than normal levels of insulin, and they're slow to return back to the baseline values. And that increased insulin, you know, goes down to the lamina and really affects the blood supply there, and then that's why we get the separation and the inflammation. Typically, EMS horses are very fat or easy keepers, but we can see, like in this picture, a very thin or thrifty EMS horse. And I will say, in my experience, these horses are sometimes harder to manage because they're already skinny. We've got to keep some calories and weight on them, but their insulin is very high. So how does insulin work in the horse? It's a hormone that is secreted by the pancreas in response to an elevated blood glucose. And then it the insulin is kind of like the key to, it opens up the insulin receptors in the cell so then the glucose can go in. So in a perfect world, that's how it works. Hopefully you can see this diagram. So a normal horse eats kind of the grass, the sugar, the starches. The glucose enters the blood, which is the yellow dots. Then the pancreas gives you the insulin, and then the insulin lets the glucose into the cell. But in an insulin-resistant horse, we again have the glucose. The pancreas lets out a lot of insulin, but it's not really letting the glucose into the cell. So we've got too much insulin out here, and we do have a little bit too much glucose out here too, and that kind of leads to our metabolic issues. So there's a lot of debate about what the best terminology is for equine metabolic horses. Are they insulin resistant or are they insulin dysfunction? And the insulin resistance really is when the cells become less sensitive to the insulin, and that makes them have an impaired glucose uptake, and then we get more glucose from the liver and we get more fatty acids in the blood, and then the insulin becomes really ineffective at clearing the glucose in the blood, and the glucose remains high. So then we have kind of a prolonged hyperinsulinemia. And there are some horses I think that is true for, but I think a lot of ours are more the insulin dysfunction, where it's just abnormal insulin metabolism in response to kind of normal diet and normal physiological processes such as eating. So really any abnormality in insulin metabolism can be referred to as insulin dysregulation. So I think that's a pretty good term to use for equine metabolic syndrome. And then we get often asked, do horses get diabetes, and is EMS very similar to diabetes in people? And it's a little bit similar, but it's not. And there's only a few case reports ever of a horse truly being diagnosed with diabetes mellitus, because that's really characterized by a hyperglycemia, so high glucose, resulting from a lack of insulin or insulin resistance. And that, again, is very rarely seen in the horses. Our problem is we get the glucose doesn't get too high, but the insulin gets really too high, and that's what causes the damage we see with the laminitis. So the clinical signs, typically in our EMS horses are kind of like this fat pony. We've got, some definite fat pads going on. We've got a bit of a crusty neck. Laminitis can be a clinical sign. The divergent growth rings, lethargy, and then difficulty getting these horses to lose weight. And again, like I said, we do have some that are skinny, and those are kind of a trickier. So the key here with divergent hoof rings is a lot of times you'll see hoof rings on a horse, like if we change their diet, and sometimes that can be a good sign, like we've got better hoof growth going on. But when we see divergent growth rings, meaning kind of at the toe in the front that they're closer, and then as we follow them out to the heel, they get wider, that is a sign that there's been a laminitic insult in the past, basically, because that's already grown down, so that's at least like 3 or 4 months. But again, here you can see how it's much wider here than there. So just seeing a growth ring does not mean your horse has laminitis. But if you see these divergent growth rings, that is a very common sign. But again, you're not going to see this till like well after the laminitic insult has happened, most likely months. And then again, this is a nice picture of a nice crusty neck. And with EMS, we definitely have the breeds that are prone to it, and there's a lot of them. We do see it less commonly in thoroughbreds and standardbreds, but one of my worst cases currently is a standardbred, and we can't really quite explain why he's so metabolic, but he is. So kind of any horse, especially based on their diet and their exercise and the management, can be at risk for equine metabolic syndrome. So how do we diagnose this? We see the clinical signs, especially if we've seen laminitis, but if we have a overweight horse, And also kind of what breed they are will kind of make us highly suspicious, the history. And then metabolic testing, we have resting insulin, adopectin, glucose, triglycerides, bile acids, and then we have an oral glucose test for those horses that were like, they're kind of on the bubble. And then I think foot radiographs, and then kind of going over what the diet and management is very helpful with helping us diagnose it. So whenever I see a horse that I'm testing for metabolic diseases, I get a resting insulin. I try to pull that 2 hours after they've had any sort of major grain meal. They can be on hay or grass. I don't really prefer to do a fasted one because that doesn't really tell me how their body's responding when they have food in their system. But if you pull it too close to a grain meal or something like that, there will be a bit of a peak that is a little bit harder to interpret. And then there's a newer test that came out from University of Pennsylvania, New Bolton, about 2 years ago. It became commercially available, and it's called adopectin. And it's a hormone in horses that help regulate blood sugar levels, and it's a marker for insulin dysregulation and laminitis risk. And I've really used this test kind of instead of the oral sugar test. It's a little confusing because the lower the number, the worse it is. So we want it to be above 8. And the lowest I've had is that standard bred was 1.6. And I've had some minis at 2. And so that just tells us that these horses definitely have equine metabolic syndrome, and they're at a high risk for laminitis. And all the ones I've ever pulled that are that low actually have laminitis at that time. But it's a good screen for, your older metabolic horse of kind of how worried should I be that this horse is going to get laminitis. And the nice thing about that test is it's not related to feed-in or stress. You can pull that at any time, and that's going to be pretty consistent. The only thing with that too is that's not going to change much. I only check that usually once a year on horses to see it. And the sad thing is there's not a whole lot we can do to improve that number. And I think owners don't like that. But for me, it's a good marker of how concerned should I be this horse is going to get laminitis. And glucose is good to check just to make sure we don't have hyperglycemia, but I don't see that at all in my metabolic horses. I check the triglycerides because every now and then we will have one that has hypertriglyceridemia, and we have to manage them differently, and then that also limits some of our treatment options we're going to talk about in a second. If I'm worried about the horse's liver, we can do the bile acids. That just tells us how well the liver is functioning. And then, like I said, we used to do this oral sugar test where we'd fast them overnight, pull a baseline insulin glucose, and then we'd give them some Caro syrup orally, and then we would re-pull that at 60 and 90 minutes and see that curve and see how high it went and say, yes, this horse is equine metabolic. But now that I have the adopectin, I don't feel like the need to do that as much. And then based on the age of the horse, if the horse is over 15, I do recommend we check an ACTH just to see if we also have Cushing's disease, which we're going to talk about later. So this is an example. This is a 20-year-old miniature horse that lives on Cape Cod, and he's had very severe laminitis for the last 3 years. And so again, the nice thing about the Penn Vet Lab is they'll give us a real number for the resting insulin. I love the Cornell lab, but they just tell us if it's above 200, that's their cutoff. So for him, before UPenn opened their lab, all we knew was his insulin was above 200. I had no idea that it was 2,000. So that's a little bit of a game changer. And then we did the adopectin on him, and it was very low at 2.1. You can see his glucose is slightly high, but I feel that's pretty insignificant. The triglycerides were a little bit high, but his bile acids were normal. He had already been diagnosed with Cushing's and was on Persen for that and has been well maintained there. But this really, when this lab opened up for us in December of 2023, this really helped us get more information. And we'll talk about him a little bit later in the treatment, but he has a good ending. But it is interesting to see how high those insulins can be. Anything above 20 is kind of 20 to 40 is where you really want it. So 2,000 is very high. So management with these, diet modification is really key. And I know we all hate to soak hay, but I feel that that's a big part of managing these metabolic horses. We want low sugar, starch feeds. I do think vitamin E supplementation is important because, again, a lot of these are on soaked hay. We want a mineral vitamin balancer, but the key is we don't want to starve these horses. A lot of times they get laminitic and then it's like, oh my God, we can't feed them, and we starve them. And then if they get in like a negative energy balance, then we have liver issues and other things. So I want to, like, over time, get everything to go down, but I don't want to immediately make a horse with an insulin of 2,000 go down to normal in 2 weeks. And then having a good farrier and having good hoof care ahead of time, but also when we have metabolic syndrome is really key. You want to keep them on a good trim cycle, at least every 4 to 6 weeks, and even less if they're laminitic. I think taking farrier view x-rays is very helpful to see if there's any evidence of previous laminitis, see kind of what sort of sole depth we have, and know what we're working with ideally before we have any problems. And then address any hoof issues like thrush or white line disease, because that's just going to make, especially white line, will make it more prone to getting laminitis. And we do have some medications. We'll talk about those. I'm not a huge supplement fan, but I will briefly mention those. And then exercise. If these horses are sound enough, exercise is a really great way to keep the insulin in check. So diet, again, everything should be done gradually. Except if this horse is laminitic and he's out on a big grassy field, he should come off of that. And then, we don't really want to feed any grain or treats, but if we have sugar-free treats, that's okay. And then we want to provide a good mineral vitamin protein balancer. And then I said the vitamin E, I think, is very important. And then if we have a skinny metabolic horse, we can add in corn oil because that's a safe fat source that's not going to increase the sugar and hopefully will help them maintain their weight. And it's important, it's difficult with hay to test the hay or not test the hay. It kind of depends on if you have a big hay loft from the same field, yes, it might probably make sense to test it. But if you're getting new hay every 2 weeks, it's probably not, it doesn't really make sense to test it. And I am kind of still a believer of even if you have a NCS below 10% and you have a metabolic horse, I think you should still stoke the hay because that's going to decrease any sort of peaks we're going to get with the insulin. And it's just a safeguard because you don't know exactly what every bale's analysis is. And then it's good to do kind of a slow feeder, divide the forage throughout the day because these guys obviously aren't going to be eating free choice hay, and we don't want, again, to increase the risk of colic or anything like that. And alfalfa hay, to some degree, is safe for EMS horses. I mean, we don't want to overfeed it because it has other, the protein and the calcium can be a lot, but, 1 flake a day of that is safe, and there's no concerns with that. So in this day and age, they've come up with a lot of hay soakers. This one, that little mini on the Cape, he has this one, and it's controlled by Bluetooth, so they can turn it on when they get up in the morning, and it'll soak, and then it has a great drain, and so when they come out to feed, the hay is ready to go. So that's pretty snazzy. And then this hay soaker is also really helpful. I mean, it's not Bluetooth, but you put it in there, you soak it, and then there's a drain at the bottom. But the muck tub with a hay net or just a muck tub in general is fine. But to note that steaming the hay is not the same as soaking it. I think a lot of people get confused. And steaming is great if you have a horse with a respiratory issue, but it's not going to take out the sugars like soaking is going to do. And then there are other forage options. There's the safe starch hay. But if you've got a mini, that's probably doable. But if you've got a horse, that's going to be very expensive if that's going to be your forage source. And I find a lot of horses do not like to eat it. I don't know what you guys do, but some horses just, because I think it's safe starch, it doesn't have much sugar in it. But Timothy pellets, alfalfa pellets or cubes, and beet pulp's fine as long as it's sugar-free. So now get into the medications. A commonly used medication for metabolic horses is thyroid L. And it's really used kind of for horses that are having trouble losing weight, or if we really want to accelerate the weight loss. And really they should be getting about 4 scoops of that once a day. So sometimes I'll split that up to 2 and 2. And again, we also need to control the caloric intake. This isn't gonna work alone if we're not making other changes like soaking the hay. And it takes a couple months for the weight loss to come off, and then you can kind of gradually, it's important to kind of taper it off before you discontinue it. But it can be a good option. Some horses don't like the taste of it. And some horses it seems to really help, and others it doesn't. And sometimes at that higher dose, we can see some weird side effects. Some of them can be very hypersensitive or kind of agitated, so you kind of have to see how your horse responds. There's another drug called metformin, and it decreases the postprandial glucose and insulin concentrations. And theoretically, it sounds like it should be really good. The problem is in the horse, it has a really low oral bioavailability. In fed horses, it's only about 4% bioavailable and 7% in the fasted horse. So it's really quite low. And we used to always have you feed it 30 to 60 minutes before you fed the meal. But some new research shows you can give it at time of feeding. I have a few horses that this works like amazing on, but most of them it doesn't really help them. So, I mean, I do try it, but I don't have that many that's the answer. And then these are the newer drugs. They came out a couple years ago, and they've been kind of a big game changer, especially for our ones where we've done the management, we've done the thyroid out, the metformin, and we still have, like that mini, he was on thyroid out and metformin and Sote, and he had a 2,000 insulin. So he went on this medication, and this medication works by preventing the kidneys from reabsorbing the glucose in the blood, so then that helps lower the insulin out. So basically they're kind of peeing out the excess glucose. And when these first came out, we said, they probably should only be on it for like 3 months. A lot of them stay on it. That mini is still on it because we find that if he comes off of it, his insulin goes back up. And we do think it's important to check their triglycerides when they're on it, because we will see kind of a bit of an increase, but we've never seen anything extremely, or at least the research hasn't shown any horses have died or anything from the side effects. But if I have one that already has high triglycerides, I won't put them on it. And then I can't really pronounce all these names, but these are all the different ones. But a real big game changer was about a year or 2 ago, Wedgwood Pharmacy came out with a compounded flozin. Because before that we had Siglatro, which was a human compound, but even for a miniature horse, it was about, I think, $1,100 a month to treat it. And now through Wedgwood, I think it's about like $55 a month to treat them. And I think there's some other compounding companies now that have it. So, with these medications, you still have to do the Sote and the good management. Like, I don't want to just jump to this medication. I want to make sure, but in the acutely laminitic horses, it can really help. And we do feel like it also has some kind of pain components. Like, it does bring the insulin down, but it makes a lot of those acutely laminitic horses better. And it's given once a day. And the key is you don't give thyroid out or metformin with this. So you don't do all of those. You either kind of do those two or you do this one. But it's nice that it's definitely much more affordable now. And then people always ask about Ozempic. And there has been some research in horses. The biggest problem is, Ozempic for people is super expensive. It's very much cost prohibitive in the horse right now. But on the research front, it's been very promising, and it's shown some really good results. And basically the Ozempic, the GLP-1 agonist, slows the gastric motility and kind of decreases gastric absorption. But then there's another category, the antagonist ones, and they actually block the additional insulin release. And those actually might be a better treatment for horses, but those require like multiple times a day dosing, which can be kind of tricky. But I don't think anytime soon we're going to see these on the market for horses, but I think probably down the road. But I do feel like even with human medicine, we still have a lot to know about long-term consequences of this. So I definitely would not be jumping to this. And again, it's not, price is kind of prohibiting that. And exercise is really important for these metabolic horses. You know, obviously if they're laminitic and they're too lame to be ridden, you know, you can't ride them. But even just a little bit of exercise a day can make a big difference. So, you know, keep these horses working. Even if you can't ride them, lunging them can really help. And then everybody loves supplements. And years ago, Insulin Wise came out, and we were all kind of excited. I think it's a really good supplement for pre-metabolic horses, but once your horse has been diagnosed with equine metabolic syndrome, I don't think it's gonna help, and it's not gonna lower the insulin. I did a couple of studies when it first came out, super excited, and it didn't touch changing the horses or the pony's insulin. So, you know, it's not a bad supplement, but it's not gonna replace our medications and our managements. So the prognosis, you know, this is gonna be a lifelong commitment once you have a metabolic horse. And even if you just have a metabolic breed that can be prone to it, I think you need to, you know, be proactive and make sure you're not overfeeding it, hopefully exercising it, getting a good foot care. You know, and I think in horses that are prone to it or have been diagnosed with it, we really need to be checking the insulin every 6 months. And especially if there's a change, like if they get injured and aren't exercising, that's gonna be a time we're gonna be really concerned. And then unfortunately to me, soaking hay is the key. And I know it's hard, and I know at board and barns can be difficult, but even if you can just soak 1 meal a day, that can help. You know, even if you can't, or the barn won't commit to doing all the hay, you know, or obviously in the winter up north when it's like 0 degrees and you soak it and then it freezes, like, you know, that's, that's not an option, but just even a little bit of soaking of the hay in a metabolic horse can make a big difference. And then this is a picture of Romeo. He's the one that had the blood work with the insulin of 2000, and we put him on the gritelflosin, and after a few months he had an insulin of 30. It's now creeping back up like closer to 100, but he's very sound, and it's made a world of difference for him. So any questions on equine metabolic syndrome? Yes?
So my experience with the current closing has been initially it managed the insulin level very well, but then it's been creeping up. So, and this seems to happen in a lot of EMS horses. So do you have any thoughts about what's going on? He seems fine though. I mean, he's so much better.
Yeah, so the question is about the articuloflosin. It initially gets it down and then it does seem to creep up, and we've seen that with Romeo. And I talked with Dr. Van Apps at New Bolton, who does a lot of this research, and there is some thought, and we've done this with Romeo before, we take them off of it for a couple of weeks, like during the good time of year. Like his time of year, bad time is usually the winter time. So like April, May, we'll take him off it for a couple of weeks, and then when we need to put him back on it, you know, then we see a better response. And we've also had to kind of increase, at other times of the year, also increase the dose a bit higher than what he normally was on.
So when you say increase the dose, how high can you go?
How high can you go? I mean, that's kind of a little bit of a question, and you've got to monitor the triglycerides. But I think the normal dose is like 0.05. I think he's up to like 0.07. So, I mean, again, but I would definitely work with your vet and definitely keep an eye on the blood work. But I think, again, we're still learning a lot by this drug, but we are feeling more comfortable keeping them on long term, but we do kind of see that kind of lose effect, unfortunately. Okay, any other metabolic questions? Yes?
So if your horse has normal ACTH and normal insulin, but has had laminitis, that doesn't suggest that they're metabolic.
Okay, so the question was if your horse has a normal ACTH, which we'll talk about shortly, and a normal insulin, but has had laminitis, that doesn't mean they have, what, metabolic syndrome? I feel like one moment in time of checking an insulin and ACTH does not dictate their entire life. So at that moment in time, they're fine, but we don't know if, you know, when they had the laminitis, was there an insulin spike? That's where that adopectin test, I think, comes in very helpful. Because that says, okay, are they prone to metabolic syndrome, and is the laminitis related to the metabolic syndrome? I had a young horse that had evidence on x-ray of laminitis and had been lame, and he was a little bit overweight, but his adopectin was completely normal, and we realized through kind of finding out that he had just had really bad farriery and had really long, hadn't been trimmed regularly, and that's where his laminitis came from. Yes?
What does the adopectin test cost and how is it done?
It's just a blood test, kind of like the insulin. It's probably a little bit more than the insulin, but like New Bolton does like a whole metabolic that you can do, insulin, adopectin, ACTH, triglycerides, I think, and it's like $225 to do all of them. I think an adopectin alone is about $120, maybe $100. So, and again, that's not something I'm going to check all the time, but I find it very helpful, especially when we're trying to figure out, is this horse metabolic or not? I mean, the other option would be the oral sugar test too. So, but it is frustrating because it's not completely black and white, and things can change a lot with their diet, with their exercise, with their weight. And that can change it. Yes?
Is New Bolton the only place that runs that full panel?
New Bolton is the only place I know of that does adopectin, yes. A lot of other labs will do insulin, ACTH, and all of that, but they're the only lab in the US that I know that does that. And unfortunately, a lot of vets don't know about it either, so I try to tell people, like, and they're a great lab worker, and they get the results back within 24 hours too, which is really nice, especially if you have a bad case that you need answers quickly. So
can you just randomly do the adopectin and learn something?
So the question is, can you just randomly do the adopectin and learn something? Yes, I think so, yes, because that's kind of a more long-term kind of test, and it's not going to be affected by what they ate or their exercise. So I think that is a good test if we're suspicious that the horse is metabolic. Like, I have a Morgan, and he's only 6, but I know someday he's going to get equine metabolic syndrome. So I check his adopectin yearly, and his is like 12. So anything below 8 is concerning. So I feel right now that he's not at a high risk for metabolic syndrome or laminitis, but I have a feeling in the next 4 or 5 years that's going to change. So, okay, I'm going to move on to Cushing's, another fun metabolic disease. It's also called pituitary pars intermedia, and it's a disorder that we see in about 20% of aged horses. And we used to think that number was much higher. So it seems like a lot, but it's not super high. And really, it's only in horses over the age of 15. It's very rare in anything under 10, and that's usually related to some sort of tumor, and and those horses have other problems too. PPID can affect any breed, and it's a condition where basically the pituitary gland overproduces ACTH. And this is due to a loss of dopamine from the hypothalamus. And horses with PPID have a high circulating ACTH, which then causes the adrenal gland to increase more stress hormones, including cortisol. And then that has kind of multiple health effects on the horses. So the name Cushing's came from Dr. Harvey Cushing's, who in 1912 diagnosed the first human patient. And the first horse was diagnosed with PPID in 1932, and they noted that there was hyperplasia of the pars intermedia portion of the pituitary gland. So it's kind of impressive that this has been around about 100 years for horses, but I don't feel like we still really understand it, and I don't think we have the best tested. So just briefly, in humans, it's because of too much cortisol from the adrenal glands. And the pituitary gland has produced too much ACTH, and then the adrenal gland produces too much cortisol. In people, we get kind of fat pads, abdominal stretch marks, bruises easily, thin arms and legs, and kind of a big abdomen, and sometimes some red cheeks. And then it can be very confusing because equine Cushing's and canine Cushing's are not the same. Interestingly enough, cats and goats and pigs don't commonly get Cushing's, but dogs do and horses do. But in dogs, it's kind of hyperadrenocorticism, and it can also be due to medications in humans, cats, and dogs, but we don't see that in horses. And in dogs, the tumor's in a different location. It's in the pars distalis, not the pars intermediate. And in dogs, it's kind of, we have the option to do surgery or medication to fix it. So surgery can fix that. And we'll talk about options for horses. But in a normal horse, we have our hypothalamus, and then this is our pituitary gland with our pars intermediate, and we get dopamine from the hypothalamic neurons, and that inhibits the cells in the pars intermediate from producing too much ACTH. So it kind of produces ACTH at times of stress that are appropriate, but doesn't overproduce it. And there's other peptides involved too. But then when we have a PPID horse, the hypothalamus, the dopamine neurons kind of have oxidative stress and degenerate, so then they don't produce enough. So then that pars intermediate produces too much ACTH, which then, and the other peptides too, and that causes our clinical signs. So what exactly is ACTH? It's adrenocortical hormone, and it's produced by the pituitary gland, and then it stimulates the adrenal gland to release the cortisol, which helps the body deal with stress, but then when that's in overdrive, that's not good. ACTH comes from the POMCs, and those are located in the brain and other body tissues, and those play a lot of roles in PPID too. We just don't have the tests in horses or even really in people to identify those, but I hope someday we can, because I think those might be better diagnostics than ACTH. And in a normal horse, a not cushingoid horse, the ACTH, most of it is produced by the pars anterior, not the pars intermediate. But when we have this hyperplasia or kind of overgrowth of the pars intermediate in the PPID horses, then that area kind of takes over producing the ACTH. But the tricky thing with ACTH is it'll also be produced when a horse is stressed, when they're in pain, when they've been transported, or when they have Cushing. So even in a non-Cushing horse, if we transport him somewhere and we pull an ACTH right after arriving, it's going to be quite high. So that makes this not the best test. You know, it's not black and white. And then the other interesting thing is in research that we find kind of normal concentrations for ACTH can depend on the breed of the horse and the color of the horse. So, you know, it's definitely not as simple as we all would like it. And then, like I mentioned, there are some other hormones that are also involved with PPID. TRH, which there's a TRH stim test we'll talk about in a little bit, that can stimulate release of ACTH. And then we have the POMC peptides, those also stimulate a lot of other hormones. Insulin, you know, a lot of these PPID horses become insulin resistant. And then the cortisol too, when that's high, that can weaken the immune system and affect metabolism. So too much ACTH in the horse causes, you know, a lot of these clinical signs where we get delayed shedding or, you know, just shedding on one part of the body, muscle wasting, especially the top line. These horses can sometimes be skinny, but they often have fat pads present. People will notice that they seem to be drinking and urinating more, sweating abnormally, having some behavioral changes. We can have trouble if we're trying to breed these horses. Laminitis is, you know, can be from too much ACTH and the cortisol and the insulin effects. And then these horses can also get frequent infections. And then we can also see tendon and ligament laxity, which is a concern if you have a, you know, a horse with Cushing's that is, you know, a competition type horse. So the clinical signs, again, are very similar to what we see with excess ACTH. The hypertrichosis, which is that excessive hair growth and lack of shedding, that's pretty pathognomonic for Cushing's. We get our fat pads, our crusty necks, the laminitis, the muscle and top line loss, the tendon and ligament laxity, the chronic infections, usually kind of dental and sinus infections. We can see higher intestinal parasites, delayed wound healing, especially with corneal ulcers, lethargy, the increased drinking and urinating, and the reproductive issues. So there's a group called the Equine Endocrinology Group, and it's about 6 kind of experts on equine endocrinology, and they meet every year and they either review metabolic syndrome or Cushing's disease, and I'll have their resources at the end, but they're a great source online to look at. And this table here just kind of tells us, you know, kind of shows what the early subtle clinical findings of Cushing's is, and then more advanced, and then kind of, you know, what's strongly suggested that they have it. You know, if they have that really long, shaggy hair coat that doesn't shed out, you know, that's pretty, you know, convincing that they have Cushing's. But you can't get confused. I get some people confused, like, I had one client, they clipped the horse, you know, in like December and January, he had grown back the winter coat, and they're like, he must have Cushing's. That didn't have anything to do with that. That just had to do kind of when they clipped him in his hair cycle. It's more so when they have that long, thick, or thinnish hair that doesn't want to shed. And then, you know, we've kind of been over a lot of these, but again, this is a good resource. And then, you know, our concern about laminitis, so PPID and insulin, and many of the PPID horses have insulin dysregulation, and some of it's related to the increased cortisol, which can cause a degree of resistance to the insulin, kind of to a horse that wouldn't normally be prone to being insulin resistant. And again, some of these PPID horses can be thin, but they can still have an increased insulin concentration and be at risk for laminitis. And we can also see like different fat areas, and then some of them will have, you know, kind of a swollen looking sheath or mammary glands. That's kind of a sign of PPID. And then insulin dysregulation places horses with PPID at a higher risk of developing laminitis, which is what we're trying to really avoid. So what sort of testing options do we have? I think it's really important to make sure we have some clinical signs before we say, is this horse got Cushing's? Just because they're 15 doesn't mean that they have Cushing's. So then, you know, if we're going to test them, I personally like the baseline ACTH. Again, we've got to pull it at a time that the horse isn't stressed, hasn't just gotten off the trailer. And we do have seasonal rises in ACTH, but we now have enough data. We have reference ranges, so we feel kind of comfortable doing a baseline ACTH any time of year. But again, if this horse is really stressed or painful, that might not be the best time to pull the ACTH. And then there's another test called the TRH stimulation test, where we pull a baseline ACTH, administer a TRH, and then in the vein, and then we pull an ACTH sample at exactly 10 minutes. Research has shown if it's not pulled at exactly 10 minutes, it can change the results from positive to negative. So to me, that's a little bit questionable. And there's, you know, some thought about now pulling it at 30 minutes, and, you know, that data looks a little bit better. And some horses, when you do administer the TRH, they'll do the Fleming response, where they'll flip their lip up. Some of them will cough, some of them will yawn, some of them will act kind of uncomfortable. It's very I mean, it lasts just a few minutes, but sometimes that's not really lovely to watch. But the biggest issue, I think, with the TRH stim test is we don't have the seasonal reference ranges. So really, the only time you can really use it is kind of December to June. And I see a lot of people sending me TRH stim results from like October. And I'm like, we don't know how to interpret that. The thought with the TRH stim test is basically that's, you know, we have a hyperplastic pars intermediate, and then this will make it overproduce the ACTH. So then the ACTH at that 10 minutes will be super high. I still think there's a lot more to be kind of ironed out with that test. And again, we've got to interpret the test results with the clinical signs and the horse. There was a study done that found that vets in Europe were much more likely to make a diagnosis of Cushing's based on clinical signs and not on diagnostic testing, whereas in North America, most people made the diagnosis on the diagnostic, the laboratory findings, and not necessarily clinical signs alone. And then this is interesting from the endocrinology group for Cushing tests. You know, they do say these tests are not perfect diagnostic tests. False positives and false negative results are possible. And rarely is Cushing's treatment an emergency. So monitoring and repeating the test is an acceptable approach if the clinical picture and test results seem incompatible and results are difficult to interpret. I think that's a big take-home message for owners and for vets, because I think a lot of us see that ACTH is 2 numbers above normal and that horse has Cushing's. But I think, you know, again, without clinical signs and we don't have perfect testing, you know, and then they have a good point, you know, for an older horse that has many or, you know, has advanced clinical signs, you know, use the lower end of the threshold for the reference ranges. But for a younger horse without many clinical signs, definitely use the higher range, you know, to try to make that diagnosis. So this is partly what's kind of confusing here. We have ACTH along this axis, and then we have the months, January to December. So you can see we have a very big gray zone when it comes to end of summer and fall. So a horse with an 80 ACTH may or may not have Cushing's. You know, if we have one up in the, you know, the hundreds or the 200s, really any time of year that's going to be a positive. But then again, the unlikely and the gray zone really changes with the seasonal rise. And some vets prefer to pull an ACTH in the fall because they feel like a Cushingoid horse is going to have a higher response, which might be true, but the gray zone is much higher in the fall. So I think that can be tricky. And this is a similar table. Again, you can get it from the equine endocrinology group that kind of goes through the different months and how likely based on the results. And we have the TRH stem and the baseline. So why do we see that seasonal rise in ACTH? It's basically, you know, before we domesticated the horses, they had to cope with having like climatic stresses and periods where they weren't going to have as much food. So as soon as the days start to get shorter after the summer solstice, there are changes in their hormones, specifically in the alpha MSH, kind of from August through October, that gets the body ready to metabolically for the winter. And that's why we see that kind of seasonal rise in ACTH. It's also interesting, based on the breed, that seasonal rise can be a lot bigger. So there was a study where they looked at Andalusians and standardbreds, and Andalusians had an 83% higher ACTH in the fall than standardbreds. And then they looked at Shetland ponies and thoroughbreds, and Shetland ponies had a 267% higher ACTH. And this is for normal horses, not Cushingoid horses. So you can see there's a lot that's affected by breed and things like that. And then the research has shown that gray horses have a higher seasonal rise of ACTH in the fall. I can't really explain that, but you know, that just tells me that there's a lot to do with these tests. So I get this a lot. You know, my horse is in the gray zone with the PPID testing. What do I do? So, you know, I say we got to look at the horse. What are the clinical signs? If there's clinical signs present, you know, then I think we should treat. If we want to do further diagnostics and it's the right time of year, we could do the TRH stim test. But if there's no clinical signs present, I would say, you know, let's just monitor this and recheck it in 3 to 6 months, or if clinical signs arise. And there's no research really that if you diagnose it or treat it early, you're going to really affect the progression of it. I feel like every horse is going to progress with PPID however they're going to. So again, if we don't have clinical signs yet, I think it's safe to say we're going to wait. But I do think it's important to make sure, and we'll talk about this later, that we check their insulin too when we check their ACTH. Because if they have a normal insulin and a questionable ACTH, I'm very comfortable waiting. But if we have a high insulin and a higher risk of laminitis, then we probably want to be a little bit more proactive with the Cushing's diagnosis. So what are our treatment options? We have some medical treatment options. I do have surgical treatment up here, and we'll talk about it briefly, but it's very early on in the research stages, so it's definitely not available, and I'm not sure ever will become. So our main medication is Pergolide, and there's a FDA-approved product for horses called Presend, and it's a dopamine agonist medication. You administer it daily, and it kind of helps with the clinical signs, but it does not shrink the tumor or, you know, the hyperplasia of the pars intermediate. So this drug was originally used in people to treat Parkinson's, but was taken off the market due to some cardiac side effects, but we don't see those in horses. Pergolide or Presend acts very quickly, and it suppresses the pars intermediate within a few hours after you give it orally. It doesn't accumulate in the body, and it takes about 3 days to kind of really get to the highest level, and then it's cleared out of the system very quickly. It has a half-life of about less than 12 hours, so it doesn't stick around super long. Unfortunately, the side effects of Pergolide in horses is not ideal. We see a lot of anorexia, meaning they don't want to eat, and I feel like I see a lot of it with the Presend. I think the Presend doesn't taste well, but also I think how it works as a dopamine agonist really decreases their appetite, and I'll see it sometimes when the horse first starts the medication, but I'll also see it on horses that have been fine for like 2 years, and then they'll stop eating. And then some horses, especially early on the medication, can colic. I have seen some pretty significant weight loss. That's usually tied in with the anorexia. Changes in behavior, attitude. I have seen some horses get really kind of dull on it. Diarrhea can be a side effect. But again, like I said, these can occur kind of any time that they're on it. It doesn't just happen early on. And if I see these side effects, I usually take them off the percent and see if it gets better, and then we have to figure out the right dose. So the question is, how do we know that it's working and are we at an effective dose? So really the keys is the improvement in clinical signs and the insulin status are the most important indicators of response to treatment. And most horses will see the ACTH go down, about 44 to 75% will go down, but only about 28 to 75% of that will go back into what we call the normal reference range for ACTH. So, you know, it can still be effective even if we're not in the normal range. And again, that's another time where we want to look at the clinical signs and the insulin. This is another nice table from the endocrine group kind of going over how do we know, is it working or not? And again, it's mostly clinical signs. We want to see the laboratory results get better, but they may not be perfect. So I'm just going to briefly discuss a couple other drugs that have been used. Ciprofloxacin, which is an antihistamine, but at higher doses, kind of has anti-serotonergic and anti-dopamic activity, and that's what helps with the Cushing's. The only thing is over time it really loses effectiveness, and it's not nearly as effective as the Pergolide. In a study they found that the Pergolide improved the horses 85% of the time, whereas ciprofloxacin only improved them 28% of the time. I will, in really difficult to control Cushing cases, combine ciprofloxacin and Pergolide and sometimes have better success. And then the first drug that was used was bromkripidine for Cushing's, and the problem with that is it has to be given kind of multiple times a day subcutaneously. Oral absorption is not that effective. But there is some more research now looking at that for insulin regulation, and we also use it for inappropriate lactation in some mares. It's just not as effective as we would like. So it's not used really to control Cushing's unless we have, unless the horse doesn't respond to any other treatments. And then there is a group up in Canada looking at doing surgery where they can pass kind of a catheter through that kind of sinus and through a blood vessel and get to the pituitary gland and then kind of chemically ablate the pituitary gland. The big concern though is they can't just ablate the pars intermediate. They have to ablate the entire pituitary gland. So the question is, long-term, what other side effects are we going to see with that? And where the pituitary gland is located in a horse, you're not going to do brain surgery to get in there and take it out. But I mean, it would be great if we could find a way to get rid of or shrink the pars intermediate, then we would get rid of the clinical signs of Cushing's. So again, when you're managing a horse with Cushing's, we want to have good health care. We want to make sure they get regular dental exams, good health care, regular vaccines, make sure they're up on the deworming, clip them if they have the long shaggy coat, blanketing, because even though they might have that really furry or thick, what we think is a thick Cushing coat, the hair is really thin and it's not nearly as thermodynamic as a normal horse coat. Proper nutrition, we don't want them overweight, and then I think at least once, but ideally twice a year, ACTH and insulin blood work. So the prognosis for Cushing's, if treated and managed correctly, these horses can do quite well. This is a Morgan mare, high over French Crystal, and she had Cushing's and EMS, and she competed at FEI dressage. But unfortunately, we did lose her to laminitis a year and a half ago, and then she was inducted into the Morgan Hall of Fame. But yeah, so the prognosis is good, but it is tough when they have both Cushing's and EMS. So so question is, if you have a cushion-owed horse, can I compete them? And the USEF now has a therapeutic use exemption, and you have to send in, your vet has to send in the blood work showing that your horse has cushions, and then they'll allow them to compete on the Percent or Pergolide, and they don't have to come off of it. Unfortunately, FEI doesn't feel like horses should compete on any sort of medication, and they will not allow horses on Pergolide to compete, so they have to come off of it to compete. So when Crystal was competing in FEI, we took her off the Percent a week before she would compete. You know, and she did fine. It's just unfortunate that they don't allow that. And then for EMS medications, the Thyroid L is not allowed by FEI, but is allowed in the oral formulation by USEF. Metformin, not allowed by FEI. USEF, you can do it, but you have to do a medication form, and they can't be on it for 24 hours before competing. And then the erticaprofloxacin, can't use it in FEI. USEF, you can use it with the medication form in 24-hour withdrawal. But my thought is, if your horse is, you know, bad enough or laminitic enough to be on erticaprofloxacin, he probably isn't sound enough to be competing. So I feel like that's kind of a mute situation, but so any questions about Cushing's disease? Okay, so I'm going to kind of talk about the relationship we have with EMS and PPID, because that kind of, they're both risk factors for laminitis. And a recent study showed that horses with hyperinsulinemia-associated laminitis showed that when EMS and PPID occurred together, their baseline resting insulin is higher than a horse with just EMS or PPID. So these ones that have both, it's kind of a double whammy, and we really need to make sure we're really addressing getting that insulin down. So this is a nice table, again, from our equine endocrinology group. We got a horse that's obese, we got a horse with insulin dysregulation, and then we got a horse with Cushing's. If you've got all three of those, you're at a pretty high risk for laminitis. But a fat horse that's got insulin regulation also is, and then you got insulin regulation and PPID, that's a high risk. But again, if you're in this zone, you're at a very high risk, and we need to be staying on top of everything. So the real question is, what can you do now? So this is a picture of my little Morgan kind of showing his little big round bum, you know, and like I said, he's gonna get metabolic syndrome when he gets older. And his mother had Cushing's at a relatively young age, and she had a lot of laxity in her tendons and ligaments, so I'm hoping we don't follow in that footsteps. But I think if you have an equine metabolic prone breed, it's good to get metabolic blood work, you know, yearly for the clinically normal horses, but maybe twice a year with horses that have some clinical signs, either some fat deposits and things like that. And I think getting baseline farrier radiographs, maybe not yearly, but getting them at least once so we know what that horse's normal foot conformation is. So if we start to have rotation or sinking, we have something to compare to. So my guy gets radiographs twice a year, and he gets blood work once a year. And then you really want to make sure you have a good relationship with your vet and your farrier, and you tell them that you have concerns about this horse having metabolic disease. Because the farrier, you know, is really looking at that foot a lot, and they can see a lot. They can see some stretching of the lamina, and they might, you know, not think to mention it or say it, but if you say, hey, I'm concerned about this, let's stay on top of it. That can be really helpful. A good exercise program, if possible, is a really good thing to start, and then a good diet and limit any possible triggers in horses that are prone to EMS. My horse loves grass, so right now he still is allowed to get some grass, but you know, as he gets older, his life's gonna look like soaked hay and probably not a lot of grass, but I'm not telling him that now. So Boehringer-Ingelheim does a great thing where they offer free metabolic testing every spring and every fall. I think they let each vet do about 2 free tests a season, and they check the ACTH, insulin, glucose. I have talked to them about adding in the adopectin. I'm not sure if that's happening this year or not. But the key is the horse can never have been tested before, so they can't have been diagnosed with Cushing's. Metabolic does not rule them out. It's just Cushing's that we're concerned about. So they have to have some clinical signs consistent with Cushing's. But we can submit the blood work and it's free of charge, and then they use that for some of their research. But I find it very helpful for some owners that either, aren't convinced they have Cushing's and I want to convince them but not make them pay, or, an owner that, really can't afford sometimes to pay. So it's a great program, and they've been doing that for a number of years. So my take-home messages really are that endocrine testing in horses is not static, and it's not an exact science, especially for Cushing's, and that's very frustrating for vets and owners. But we need to kind of, again, take the whole picture into account, not just the numbers. And again, we need to combine the clinical signs with the metabolic testing, and I really think it's important to get the ACTH and the insulin, in any horse that we think might have Cushing's, because that insulin results really help us know how at risk we are for the laminitis. And again, it's better to be proactive, especially if you own a metabolically prone breed. And we have research looking into better diagnostic tests and treatments. And so that is kind of exciting that that's still ongoing. The University of Minnesota, I don't know a whole lot about this, but they are looking for owners of horses that are on pergolide, and they're looking at kind of some genetic factors that might explain the side effects and kind of the anorexia we see in horses. So I think this is a really good study. So if people are interested, you can go online, and I think you just need to answer some questions and send in some of their current blood work and things like that. So I'm excited to see what this study shows. And then these are the resources. I think the equine endocrinology group is a great resource, and they try to kind of make everything not too complicated. And then they update each one every 2 years, so you get the most recent information. The BI-free testing. And then the Mad Barn website, I find very useful, especially if you're trying to figure out what feeds have how much sugar or starch. They have like a great database, and they can give you all that information. They also have some really great articles on metabolic diseases and laminitis. And then they also offer a hay analysis. A lot of other feed companies do too, but they're very good there too. So any questions? It was a lot. Yes?
You didn't mention the ECIR group.
Oh, yes, that is another good group, yes. I'm sorry, yeah. I guess these are the main groups I use the most.
So, but a question, because on the net group, Keller Kelly, it's her opinion that, you should, in these EMS courses, that also have PPID, you should keep your ACTH level down in the mid-20s. Okay, which means with a horse like mine, we're up to 8 milligrams per month. He has no anorexia, but he's doing fine. But so what's your opinion in going up in the dosage so far?
So the question is kind of about these horses that have Cushing's and equine metabolic, and really wanting to get that ACTH in the 20 zone. And that sometimes means that they're getting multiple tablets of percent a day. And in her example, her horse doesn't have any anorexia. I mean, I do think, again, let's see where the insulin is. If we can get the insulin down too, I'm okay with the ACTH not being, 20. I don't want to see it above like 75, but I'm not always targeting a number. Again, depending on how well the horse is doing. Because there are some horses that are on a lot of percent, but I just wonder, would they still be doing well off of it? And I ran out of time, but I had some cases to go over, and I have a couple horses that we followed for a long time, and we had them on percent, and we took them off. We got the insulin under control, and we took them off, and the ACTH does not go back up. You know what I mean? And it goes back up in the seasonal rise in the fall, and their insulin will go up a little bit, and then we'll put them back on percent from like September to November, and then we take them off, and all the rest of the year they're better. So I kind of think, again, with the ACTH changing a lot, even in cushion horses, I think our dosing and treatment has to be more fluctuant and more, not like static. But at the same time, you can't really afford to check blood work, every day or every month. So it can be tricky. Mm-hmm.
And I can tell you, we're in several times a year with Russell. And there's been a major improvement in the rate of use with his insulin and with him.
Okay.
So I think there's something there.
Mm-hmm.
But the other thing is, we don't use percentage work, it's too expensive. We get it
You get it from Chewy?
not actually,
Oh, Wedgwood, yeah, Wedgwood and Chewy do make compounded pergolide. I haven't really used the Wedgwood, but I have had clients use the Chewy product, and we've seen very good results with it. Yeah, the capsules. And before we had Percend, we had often used liquid pergolide, but research showed that once you open the bottle, the effectiveness really died down. But these capsules they're making now seem to last a long time. And then the Percend has a shelf life of forever. Yeah, they're different. But I do sometimes still see the side effect of not eating with those other products too. But they don't, the Percend definitely has a bad taste to it too. A lot of horses, you have to hide it in a treat or get really creative about how to give it. So that's unfortunate. Yes?
Have you ever noticed any correlation between Percend and seizures?
Any correlation between Percend and seizures? I have not. Yeah.
The horse with insulin resistance, you mentioned that they have frequent abscesses. What's the physiology behind that, briefly?
So the question's about horses with insulin resistant and frequent abscesses. I think that's because we're having some low-grade laminitis, and we're having some, detachment of the lamina, and it's allowing gas pockets and things like that to get in there.